I wondered if you folks could talk about, and Jim, you started to mention this, or Joe, I think rather, the whole morality of what we do versus the cost arguments, because I think that that is a very consuming piece for us right now here in the city, especially as New York thinks about Medicaid and Medicaid cost savings, and how we can balance some of that conversation.
My Celtic tendency to overstatement tends to get me in trouble sometimes, but I think that generally there are legislators that are morally engaged and concerned about specific issues. But for the past decade in Massachusetts, in terms of unaccompanied adults in particular, there has been little or no investment per se. And we found that for the most part, and again, we're probably partially responsible for that, because if we could not show essentially what we were achieving or that we were actually solving the problem, then it doesn't become a very compelling case necessarily for expanding your funding. And so from our perspective, from a strategic point of view, and again, remember at a point in time where Massachusetts was committed to developing its own universal health care, it became a very important time to stress the relationship between homelessness and some of those health care costs. And so by that, what I meant was that, again, the need from an advocacy perspective to show that certain interventions actually work, and that, you know, what we used to say, that there's a cost to doing nothing, and displaying what that cost is, that became a very politically viable message, and people were open to listen to that and to hear that. So probably a more accurate statement it would be to say that moral arguments alone are not enough to make your case, as much as showing, one, the efficacy of the proposed intervention, and secondly, the cost benefits associated with what you're doing. So I guess I just think it's part of the realpolitik, so to speak, of achieving your end.
So I can speak like a can I speak just like a practicing doctor? Okay, I think as we heard yesterday, I'm very nervous about. I think we have to do as best we can show cost effectiveness or cost savings. I think though, if you really probe the literature, there is yet to be a sort of a randomized controlled trial that would meet evidence-based measures that shows that housing does decrease costs or improve health. I suspect it really does, but we don't know that. So, for example, the FDA would not yet be able to approve housing as a medication for homelessness because we haven't hit that standard. What I know is that for those very high users, I think we're going to show astonishing savings, and we ought to push that to the limit. I don't think we're going to show savings when we get to the folks who are, you know, if you take the people who are out never coming in and we want to house them, it's going to cost us money as a society to house those folks. But it's the right thing to do. I think the right to housing is what should prevail on this, not the fact that it's cheap or saves money. But, you know, I think we all are in this thing, as Joe is suggesting, that it's our only way to get the attention of what needs to be done now. I worry, I was going to show you a slide about if you really look long-term at these folks, and I don't know if Aaron is here now. I was listening to Aaron's discussion in your session, Scott. But if you really follow these folks long time, the housing is clearly the necessary, but I don't think sufficient condition for making sure their lives are going to be fine. I think we're talking about poverty here. So healthcare is important, housing is important, but then you've got corrections, you've got education, you've got labor, you've got all this. Those all have to chime in to be able to make this really work. And I don't see that happening yet. So I think that'll be our next phase. Let's get housing and health working, and then we'll work on the others. But I'm a little skeptical that the long-term stuff will show the kind of savings we're talking about. When I get that way, though, no one holds a hospital responsible for showing us that you're saving us money to a system. We need hospitals, and we pay for it. When we have a hepatitis C treatment, which is really phenomenal now, which everybody's going to deserve, it's $50,000 a year per person. we're going to give people that because that's the right thing to do. I suspect, why aren't we thinking like housing the same way?
There's a gentleman in the back with the red tie.
Yeah, if you could show them the statistics of when you take people who are HIV positive, if they have to make a choice between taking their meds and housing, which one comes first? Housing always comes first. You give them housing, they take their meds, because if they have no housing, then they have no place to put their meds. If you use the same analogy as far as for people who are homeless, then you get the feeble-minded people who sit in Congress to see your way of thinking. Because I agree with you. You know, as someone who's going to become a senior soon, well, I am a senior. If I don't have no housing, I'm not taking my medication. And housing makes me not go to the hospital. Doesn't make me not go to the emergency room. I see my doctor more than I ever saw him before when I was healthy. Because when you're healthy, you don't think about going to the doctor. But as you get older, you think about going to the doctor so that you don't end up in the emergency room. So I mean, show them the HIV model. Show them something. I mean, really, they can't be that stupid in Congress.
I may be wrong, okay, but by law, everyone who is HIV positive in the state of New York who's a resident here gets medication. Okay, you cannot be denied medication for any reason whatsoever, under any circumstance.
I think you still you want having access to it. Like if you're homeless, you're going to carry all your meds in a backpack.
Well, you wouldn't. Well, you first of all, you'd be prescribed medication by a doctor. So at that point, you know, you probably have some kind of residence or some kind of address that you know.
No, not necessarily.
I think we're digressing just a little bit.
Cynthia and then the woman in the back.
I wanted to follow up on what Dr. O'Connell said, which was the cost effectiveness of which we're all guilty of promulgating that particular. And I'm most concerned about it in terms of Medicaid and high users, because if we I'm concerned that if we hinge services on Medicaid, we will only be allowed to work with people who are very medically frail, and will only be allowed to work with them as long as they're medically frail. And the second that they're no longer medically frail, I mean, Joe, you're using C-SPEC dollars to do a lot of the services that we do in supportive housing, but don't they need to be attached to people who are Medicaid heavy users?
Presently with C-SPEC, the only condition is that they have to meet the federal definition of chronic homelessness. That's it. So it's not specifically, and again, I know this is an area that I tend to think that the true costs of all chronic homeless tend to get underestimated in most cases. For years I used to hear about, oh, ER, you know, the cost of ER. Well, when we did Home and Healthy for Good, I mean, we were amazed, and along with Jim's colleague, who's kind of the co-founder, Dr. Jesse Gaeta, with that we were amazed that the most acute medical stays just blew the costs off the charts. And a good part of the reason for that is because if, just as a gentleman pointed out, if you're in a shelter and you're not able to really manage whatever your chronic illness is, or if you're on the streets or whatever, it just keeps getting exacerbated and worse, and you wind up without a place to stay, in the ER, and immediately into some long-term acute stays. And I think I understand what you're saying in the sense of this being targeted to too limited a population in terms of perhaps you know, generally not being a resource for permanent supportive housing generally. But from my perspective, with Home for Healthy for Good and C-SPEC, the focus has always been on providing an acceptable alternative to shelter. I get a kick out of low threshold housing. We don't even, in some cases in Massachusetts, they're not even low threshold shelters. I mean, a poor homeless person can't even get into a shelter because of the compliance-based rules and things that are in place there. So again, I haven't I wasn't as much concerned about like laying out a full framework of the overall need that we have for permanent supportive housing, as much as trying to make a case for why we can do better than these emergency services. Keep in mind that in Massachusetts, this fiscal year 12, I think we're going to have spent probably close to $300 million just on emergency shelter resources. The vast majority of that for families, but a significant chunk of change as well for unaccompanied adults. And the question is what do you really have to show for that compared to investing these things into permanent resources and addressing the overall need?
The only other, the answer I would give to that as well, just from a clinician looking at most people that we have now who have a disability that we're talking about in this, that disability is lifelong. It does not just all of a sudden stop. So for most people, I think Medicaid won't back off. They're not going to back off on the diabetic. They're not going to back off on someone with cancer, someone with COPD, someone with heart disease. So you start to realize that, and I worry a lot about medicalizing the service. That's what I think would be bad. But I think using the Medicaid funding as one arrow in our quiver that is very powerful, through FQHC, through C-SPEC kind of programs, through, you know, community-based waiver kind of stuff, I think is the way we package the system. But I'm with you on that. We don't want to set it up so it's an all or nothing, because then if Medicaid pulls the rug out, we got nothing.
Tori?
Hi, Tori Line with Jericho Project. It's a great program you guys have. I wanted some clarification on the model, and I guess it's kind of similar to what Cynthia asked. You know, the photos that you showed were of nurses and psychiatrists making home visits. Is there also a case manager who's visiting these folks to address maybe some of the less, you know, I'm sure you don't always need to send a psychiatrist, you know, if there's just a case management need. And if so, is that covered by Medicaid, or are they linked with other case managers?
Well, I'll tell you how our team looks, and then Joe can tell you it's fun. So I didn't get to those slides.
Is anybody from Medicaid in here? I just want to know.
No.
Full disclosure.
Our team, and forgive me on this, because our team was a healthcare team that just migrated to housing, so we didn't set it up as if we should be a housing. So we've learned how to add properly. So most of the caseworkers we're working with are the workers who work with the housing programs. So, and then we sort of share it as a team. It's actually kind of fun. But we have now added, through Joe's advocacy, we now have a community health worker, which is a C-SPEC funded position, and an AmeriCorps position, and they basically run the team now. They tell us who needs to be seen and all that stuff. I could tell you a lot about team dynamics and what we have to, the struggles we've had to do to make sure everybody gets seen that needs to be seen. And that map, which I left in, that's where people are scattered all over over town. And deciding today who's going to be seen, and if you're going 2 by 2, you've got to make that structure. And if somebody's in the emergency room last night, or if the caseworker says, you know what, they've been creating havoc at home, we got to go see them. So you structure the team really flexibly, which is a tough thing for some of the clinicians to get across their mind. Joe, I'm sorry.
No, I was just going to say is that with the C-SPEC program and with our partnership with the carve-out and the managed care organization, we have very hesitant to use the word case management, because again, the way we were able to do this through our 1115 waiver is that we again have an 1115 waiver, which allows for a great level of flexibility within Medicaid, but then you also have to opt to be able to provide the community support program. What they did was they adapted or adopted, I was right the first time, adapted CSP specifically to fit this. And because of their carve-out and their managed care, we're able to be a little more flexible in how providers were reimbursed. But we've moved away from using the terminology case managers, because in Massachusetts, well, under Medicaid, there's specific meaning for that, and then there's certain clinical ideas behind that. We almost refer to this again as community support workers, or tenants. I like to even call them tenant services. The whole point being they can provide a wide range of services full-time to this specific population under the terms of the CSP. But the bottom line is that they are the frontline person. They're the person that we know. There goes that overstatement again. But I'm pretty convinced that it really is that personal contact. It is that everyday presence and that person working with that, building the relationship with that tenant that really, really increases the chances of that tenancy being successful. You know, in our Home and Healthy for Good thing, we found that if a person could be kept in the program for 5 months, they were there for just about ever, or they would be housed just about forever. And these folks are really the people who play the critical role. And the other thing that we discovered is having a platform which to work this from, a 24/7 kind of presence. And that was a way of re-engaging and converting shelters to a different view of how they saw their work. There's John Yaswinski's a director of Father Bill's Mainspring in Quincy, and he made a statement once where he was saying, I have people on my midnight to 8 shift who've done more to keep people in housing than an ACT team has. And what he meant by that was, because of the relationship there, the fact that that person feeling vulnerable or at risk or in a bad situation felt comfortable enough to recontact that program and work with them as well. Essentially, this model that I'm trying to have, you know, all over is one that really acts as that go-between between the health, between the psychiatric needs, between the social needs, whatever it might be. And, you know, we've been looking at it very carefully. I think the one thing, we've become masters at stabilization. I think the next great challenge for us is around re-engagement. But the retention rates, I think, speak for themselves, that it works.
Scott?
One of the interesting things that you mentioned were these incredibly high cancer rates of people in your program. And in the Bronx, we see much the same thing. You know, relatively young people with very, very high rates of cancer. We know that about half of the guys that are chronically homeless and on the street in the Bronx are Hep C, you know, have Hep C. I'm just curious, why do you think it's such a problem with this population?
I mean, one, it's poverty. It's abject and persistent poverty. But when we looked, just to let you know, since we couldn't look at anything else, you know, we're sort of like low-level researchers because we don't have big NIH grants. So mortality has been the one thing we could actually figure out how to look at, because you can look at national death indexes. And so we did all of that by getting death certificates. They were also our patients, so we knew what was going on. So those were medical records we did. But when we just looked, we've got a new study that's coming out that one of our really amazing young doctors is doing, where we looked at 28,000 homeless people that came into our clinics from 2003 to 2008. And once again, the leading cause of death was cancer. But when we looked at the cancers, they're lung cancer, head and neck cancer, esophageal cancer, and liver cancer. We saw no breast cancer. We saw no cervical cancer. So what it begs to say, although who can prove it, is these are smoking and drinking related cancers. So people get them younger. So, you know, your liver cancer is the hepatocellular carcinoma coming from your hepatitis C and you continue to drink. Smoking related cancers are the other ones. So we now realize, you know, why are we doing all these mammograms and pap smears we try to keep up on, but we're not seeing any result for that. But we're really probably not as good as we should be at addressing smoking and doing everything we can to do anti-smoking stuff. So in answer to your question, I think it's the lifestyle you live when you're outside and in the shelters that where smoking, I always think of it as a World War II movie, you know, when you're down to the bitter end and you have nothing left. Smoking is a pretty comforting and valuable thing, and people have a hard time letting it go. So I'd be open to discussion. That's a topic to be debated some. What we know is it is still the leading cause of death. We need to. It's something that should be prevented. We should be able to prevent it.
On that note, can you folks talk about how you integrate prevention efforts into both the on-the-ground care and what you fund?
Yeah, I think the only thing I would say about the I mean, just this last discussion highlights the importance and the need for housing, and why the cost benefit still has great merit, because I'm certain there's a number of national researchers at this point in time looking at the relationship between housing and prevention. We have to remember that these people over long periods of time fell into these situations. So if we have a more appropriate response to homelessness than shelter or leaving people on the streets, then it seems to me that that would be, as the people at Healthcare for the Homeless say, a great prescription for anyone, and particularly plays a preventative role as well. But I guess I'd have to, in terms of the actual, from a healthcare perspective, I'd leave that to Jim.
Yeah, it's an intriguing question, because there's the population level prevention, and then there's the individual level prevention. So I think, as any of you who are clinicians would say, is that for each individually there's a whole list of what we know we should be doing to help people lead better lives or make better choices. So we work like hell to do that. We used to not worry about it on the street because we were so interested in just making somebody survive till tomorrow. Now we're realizing that's part of what we should be doing. That's why I showed you the flu shots and pneumovaxes. We do pap smears and mammograms. What we've learned to do is every time somebody hits the hospital or the emergency room, we know what they haven't had yet and get it done then. So rather than set up a clinic appointment for your mammogram or your cervical cancer screening, we do it when they're in the emergency room or they get admitted to the hospital. So you can actually get really pretty good quality control measures, but it's always measured against this high mortality rate. So we're frustrated by that. Even we haven't figured out. I think substance abuse and cigarette smoking are sort of starting to emerge as the things that we have such little control of, and we're now desperately looking for better ways to see how we can collectively treat that.
Yes.
Hi, Nancy McGraw from CSH. I wanted to ask what you thought about what it would take to scale this up. So let's say there are resources that come down the pipe for services and housing. What would it take to get the infrastructure in place to really take this to scale?
Well, first I want you to make sure that you go back to Deb and Ryan Moser and tell them how highly I spoke of the Corporation for Supportive Housing. They're actually engaged in Massachusetts at the moment with Mahasa and a few others around one thing that's being proposed. Personally, I would love to see, the governor of Massachusetts put an additional $1 million into Home and Healthy for Good. It didn't sustain the legislature. They only added about $200,000 into the FY13 budget. Personally, I think that I would love to see this integrated into public funding. And again, based on that argument of the cost of doing nothing. Homelessness is created by as far as I'm concerned, a whole host of failed public systems. The public has a very important responsibility to play in shaping this. We're even seeing now that another form of, it's not deinstitutionalization, but using the whole concept of community-based services in the Department of Mental Health and relying on large private agencies. We're seeing many people disengaged from services. And where do they wind up? They wind up within the shelter system. There is a public responsibility. Having said that, everyone's aware that the public is saying they can't afford what they're currently doing. And certain things have come into play that could either be promising or disturbing, depending on your perspective. In Massachusetts, we don't necessarily have a choice because we're starting to go down the whole road of the social innovation financing or social impact bonding. And the fundamental premise behind that is the private money precedes the public investment. And I think there's some good aspects to it. I mean, the good aspects are the fact that it does focus on specific outcomes. It's very important, however, that those outcomes be social outcomes and not purely fiscal outcomes. And I think that there's also some positive ability if there is some way of reimagining or being able to tap into additional forms of capital that exist out there in order to create and respond to this. In Massachusetts, they've chosen 2 initiatives that they want to bring to scale, one being Home and Healthy for Good, and doing low-threshold housing for chronic homeless through the Secretary of Administration and Finance and the Department of Housing and Community Development. The other they've chosen is a criminal justice youth prevention program. Part of the reason it was kind of scary that they picked Home and Healthy for Good isn't because the metrics were that great, but we were one of the few social service programs using any metrics at the time that you might be able to gauge either both a social or a fiscal outcome. So in terms of bringing it to scale, that's the first thing that's there. The second thing that's been part of Mahas's mission since the 1980s is around conversion of resources. So one of the things that we failed to point out, but in the last 6 years, the street population as well as the unaccompanied adult population in Boston has decreased. And I think due in great part to a lot of these various housing efforts that are going on. As a result, that trying to convince emergency shelter programs to use their individual assistance money in a new way is critical, and that's exactly what's happening. For example, Pine Street Inn closed its night center. Its night center didn't even have cots. It was just an open space in the night, funded at a little over $1 million something bucks. It dawned on them eventually it's the same 30 people for a decade almost, primarily, that were in that particular program. They have now housed those people and have closed the night center and reconverted that towards permanent supportive housing. So those are the tiers that I think that would bring it to scale within Massachusetts. And again, it's not like we're not spending a ton in terms of sheltering. We are. And I think that this is trying to propose an alternative that ultimately has better long-term results. Part of the vision is that you're never going to, you know, it's not that you're not going to have some need for an emergency resource, but through triage, assessment, and even short-term shelter, there's better alternatives than sticking a guy into a warehouse or whatever. I think the dirty secret had always been is that the shelter system in Massachusetts the emergency was long over. It had become an acceptable housing niche for some of the poorest and most disabled people in the Commonwealth. That's what we're breaking out of now, hopefully.
I would just add, if you're talking about how do you scale up the health services part, I think a lot about this, as you know, and so is CSH. But when we look at our team, what I can say is that half of the total cost for our team comes in through our FQHC dollars. So FQHC doesn't support the team, but boy, it gives you a pretty good platform. So I'm a little stunned that we aren't doing that more around the country. And I don't know whether this is a problem because, you know, in my own profession, because I think even in our own program, we talk to our docs, they don't really see the need to go see people at home because they've got a great clinic, it's in the shelter, why don't they just come see us here? So there's a little bit of resistance, I think, on the clinicians to thinking that doing home visits is really going to be either good or effective or something like that. So we keep trying to drum up how much fun it is and how much happens and how much your patients really appreciate it. If you can allow me to say patient rather than client for a moment. But and so then what we had to do is you add the C-SPEC money, or so if you can get some other support coming, that begins to fund more of it. And then we've just relied on philanthropy or diverting dollars for the rest. But I think we're coming dangerously close to showing that you could probably pay for these through currently structured Medicaid things, as long as you can clarify with your individual, your state Medicaid departments what the FQHC rules and regs are and what your other stuff are. So I wouldn't lay it alone yet. We need a lot more work, but there's stuff there. We shouldn't leave those dollars alone. We should go for them, I think.
Jim, you've said a couple of times, you've talked about challenges and how fun they were to tackle. And one of the things you made reference to was getting your team to work together. And I wondered if you two might comment on translating health for housing providers and vice versa, and both for practitioners as well as for funders, because sometimes they come out of different worlds.
Yeah, I'm sure you guys know all this too well, but I think our first experience was learning how, as clinicians, to work with the shelter folks. And that was because we do clinics in almost all the shelters in town. Each shelter had a slightly different thing. So I remember we learned to be a little bit more humble than we had when we were in the hospital. And then the issue became, how do we work interdisciplinary wise? So how do the nurse practitioners work with the doctors was one, and how do the PAs work with the nurse practitioners? But then the real rubber hit the road when psychiatry and medicine and the people, I say those with the broad terms, started to work together. I'll give you an example. Most of the psychiatrists that I knew, when they went into a visit that was a 50-minute visit, they were not going to be disturbed. And when we see people in clinic, if somebody's having a little asthma attack, somebody will knock on the door and you have to run to that one, then you run back and you do this. It's kind of a different culture. So we would have somebody in a psychiatric crisis, but the psychiatrist was in seeing somebody 50 minutes, we couldn't knock on the door. It was kind of didn't make sense to us. So we had to laugh about, I had to sort of pull out what was going on, and then we all had to give in a little bit. But that took some time, and I respect that. And then now we've been doing the same thing with the housing work. If you're working to keep people in housing, you have a whole set of things you've got to do that are really time pressured and complicated, and then to throw in a doctor or a nurse on top of that completely upsets the apple cart, I think. And likewise, we don't understand that. So we had to do a lot of working together as a team with housing and health folks to get used to the fact that none of us owns the person. We're all, whoever has the best relationship runs the team in that case. So all of that, I think, is how we had to do it. And I have a huge respect for how difficult that is depending on the traditions from which you're coming. Because I know we all have the same goal, but we've got way different ways of getting there, and trying to learn to work together is a challenge.
I just had a flashback in terms of Jim and in terms of working together. I think he's always worked together with the homeless providers. It's amazing. In the early 1990s, shortly after I had left the Friars, I actually wound up running a shelter called Father Bill's Place in Quincy, Massachusetts. And I remember I had known Jim. I had actually met Jim even while I was still in the Friars through another friend of mine. But it was a funny thing. I called him up one day and I said, geez, you think, I really need a presence at Father Bill's right now, again, in terms of health care. What could you do? The next week he shows up, basically, to deal with the clients there. And that's kind of the approach that Jim has taken. And if he wants to point out some of the statistical flaws and the connection between housing and what it takes to keep people in housing, I think a significant portion of those first people were probably kept in their housing by Dr. O'Connell, aside from health care for the homeless. But I think one of the great things that happened with CSPEC, when we talk about mainstream resources and doing different things, is that I'm sure many people have had the experience that, particularly dealing in the realm of behavioral health and mental health, that it's very difficult to get access for chronic homeless or a homeless person into those services. With CSPEC, what was interesting was they came up with a model that allowed the licensed entity, and this doesn't refer to Boston since healthcare for the homeless plate, but in other parts across the state, now you had that agency who was passing the dollars through to that homeless provider, and for the first time, perhaps, we're actually collaborating in a way that made sense, where they began to understand how to better coordinate services and resources around this specific population. And I hope I'm not saying too much in relation to this, but one of the exciting things that they're looking at in terms of CSPEC is in Massachusetts, we've dramatically reduced the amount of public DMH, direct state hospital care that exists, and it exists primarily through a private system. And we promoted discharge planning, but when you're in a shelter and you finally get a private hospital to take this guy in and to get him some help or assistance, and then when he's trying to get him back out and you're now screaming at them discharge planning, when that person has the very same problem you have, they have no other place to send them to. So one of the things that their work is really talking about through the partnership is looking at the private system and seeing if they can't link CSPEC directly to those referral out of the hospital systems directly into a supported unit in some way, which is very exciting because it'd be the first time to acknowledge that we're all dealing with the same clients and the same people, and we should be working together to try to rectify or make their lives better.
You both lived through the shift to managed care in Massachusetts, correct? And I wonder how that, as we shift here in the city to the folks we serve who are homeless being moved into managed care, even as we speak, and people with serious mental illness having their specialty care moved into managed care. Wonder if you can talk about how that's made an impact on your work, or if it has at all.
I can only speak to the behavioral health aspect of managed care. In the 90s, when it was introduced, I was one of the people screaming the loudest in some respects, feeling that somehow our folks were going to be managed out of the system in some particular way. But again, a lot of it, I'm sure, is managed care would be contingent upon how it's structured in many respects. The carve-out in Massachusetts previously had limited risk associated with it. And so, and it also had these great, this whole great idea of the performance incentives, which became a way of setting certain objectives that were valuable. But the partnership is such that they're willing to experiment in terms of the best delivery of service, and seem to recognize that as a way also of controlling the costs of hospitalizations, for example. So I've been very happy with managed care as it has existed up to this point in Massachusetts, in that it really serves our people better than they had been served in the past in many regards. And the thing is, however, is that's changed. There's a new contract, which fortunately the partnership won, but now they assume all of the risk, the cost risks associated with this. So I don't know if that's going to change it. And the other unfortunate thing is the state made the decision for some reason was to eliminate the performance incentives. So it's a wait and see, but I have always found them to be a great entity to work with as it regards homeless persons. And personally speaking, you know, I also have several adopted children with some serious mental, and one biological child with some serious mental health issues. By contrast, the level of services available to managed care, as opposed to, you know, my own ordinary insurance, it's just absolutely incredible in terms of what that opens up to them. In fact, the former commissioner of mental health, who now runs an organization called Mass Society for Prevention of Cruelty to Children, had made the comment that if she had a mentally ill adult child, she would encourage them to basically to go on to SSI and Medicaid, because then he'd be assured of the level of services that he or she would need. So again, that's it's been primarily positive. I don't know if in terms of what's being suggested in overall health care, if it's
I wouldn't add. I think Joe's good. I think my take on it is we've been through so many things in these last, so many sea changes, that you just kind of cross your fingers and hope for the best. But what comes across to me is it's the managed care companies are going to be contracted by your Medicaid or your Department of Mental Health or however it should be, and it's that contract that really sets the tone. So that's where I think the advocacy, as Joe has been doing, is right there to make sure if Medicaid's going to contract that, these are the things we need. And I think that's been the most important thing. The practical thing for us is if you've been following somebody for a long time and know them really well, and then there's a managed care change up and they have to go to another system, that gets tough, and we haven't ever really straightened that out. We've been fortunate in the fact that most of the medical care for our folks has remained in what they call a PCC plan, which means it's not in a managed care program, it's still within either the FQHC or whatever private doctor thing. But that will probably change if we're going to cope. That's going to be a nightmare, I think.
Other thoughts or questions? Final words? Gentlemen.
I have a final word. Thank you. I can't believe you're still here at 4:30 in the afternoon. But all I can say is I have a huge respect for what you do, because as I think about this and talk about it, it is a long, long journey, and you guys have been on it for a very long time, and I really salute you for putting up with us and for doing what you do.
I guess all I can say to that is ditto. So, nothing.
Thank you very much.